So can you discuss risk-based screening? You mentioned screening, and we've been doing that based on risk-based screening. Can you tell us what that is and whether it's been successful and whether we have alternatives to that?
Well, risk-based screening is really a sort of an infectious disease epidemiology approach to public health, whereby we know the modes of transmission for hepatitis C, and so our recommendations for who should be screened follow that knowledge. So it's persons who have a history of injection drug use currently or in the past, even one-time use. Persons have a history of blood transfusion and receipt of other blood products before the blood supply began to be screened in 1992. Clinical indications like an elevated ALT, persons should be screened, and so on. Unfortunately, what we find, and this is true for hepatitis C, but also for hepatitis B and HIV, that physicians, clinicians often have a hard time delving into those risks, particularly when they're not an indication for why the patient is in their office. And patients sometimes have a difficulty revealing those types of behaviors because of their social unacceptability and stigma and other concerns. And so those all represent barriers that can be very difficult to overcome. So we're seeking alternatives to see how can we get strategies implemented that are more acceptable both to providers and patients. And given the high prevalence of hepatitis C among persons born in the so-called baby boom generation around 1945 to 1965, we are considering moving more toward a population-based or demographic-based approach, which is more used for like cancer screening. And specifically, we're looking at the values of recommending a universal one-time screen for this population because they have about a little over 3% prevalence of hepatitis C in this group. That represents about 80% of all persons living with hepatitis C in the United States. That prevalence is 5 times greater than persons of other ages. And this is the group where most of the morbidity and mortality related to hepatitis C, cirrhosis, and liver cancer is. We recently published a paper in the Annals of Internal Medicine last Friday showing that this type of approach is cost-effective and comparable to other well-accepted clinical preventive services such as colon cancer screening and screening for other chronic diseases. So we think that this has a lot of merit. There's more work to be done to really establish it as a recommendation. So it's still just a consideration. But I think we're looking for other opportunities to get screening more widely accepted as a routine clinical preventive service. Then having done that, then how do we get the providers there to actually receive that influx of patients? And I think that's where the partnerships between public health and AASLD and other types of providers that you mentioned, primary care, mid-level, clinical providers, really begin to play a role. So we really have to develop a very thoughtful and integrated approach to this. And I think the National Viral Hepatitis Action Plan that was presented at the session, which we may talk a little bit more in detail in a moment, provides a pathway to get there.
Yeah, let's talk about the action plan that Dr. Baldessari talked about. He emphasized the importance of access to care, and you're saying we may bring 1 million more people into the healthcare system by such widespread screening. One of the problems we have now is we don't have enough providers to deal with all of these patients. How do we go about getting those people? How do we provide access to these people? And one of your papers at this meeting says that 38% of these people are underinsured or uninsured. How do we get them funding for being treated?
Right. Those are the challenges in front of us, and those are the challenges that public health is charged with addressing, is how do we bring together the benefits, in this case of treatment, with a population who could really benefit from that, and in so doing, reduce morbidity and mortality, which is one of the objectives for public health. So one way of doing that is to set national priorities, and the National Viral Hepatitis Action Plan does that. This was a process that took about a year to do. I have to say that the U.S. is probably one of the few countries that has a national plan for viral hepatitis. And I think it's helpful because within the Health and Human Services, it really begins to charge, NIH, FDA, CDC, HRSA, the other agencies within HHS with responsibilities for viral hepatitis for the first time. Now, obviously, many of those were already working on hepatitis, such as CDC, obviously, and NIH. But it really begins to say, what can we be doing together better? What can we be doing more to help us achieve some goals for the future? And so we lay out goals such as increasing the percentage of people who know their status for hepatitis C and getting them into quality care. And then it outlines 6 areas where we could be addressing viral hepatitis more effectively. So in our discussion today, I think in particular the 2 areas that bear on our discussion is education. How do we prepare the workforce across the board to manage hepatitis more effectively than we are currently? So we have set about developing medical curriculum. ASLD is developing curriculum, and I think those are the types of partnerships where we really could come together and develop very effective tools to educate providers. But we need to extend that to infectious disease physicians, primary care physicians, allied health professionals, even pharmacists could play a role in screening. So I think we have to be very innovative and very inclusive and recognize that there's a lot of roles that could be played in different parts of the health system. And I think the first order of business is to stake that out as a goal for the nation. And I think that's really one of the big benefits of the plan.